Menopause and Mental Health, TOG 2023. Starting with definition, menopause is a cessation of menstruation due to loss of ovarian function, and it is diagnosed retrospectively 12 months after the last menstrual period. Regarding epidemiology, the median age of natural menopause globally it is 48 years, in the UK 51 years. And the factors that affect the age of menopause includes race. It is generally lower in Africa, Latin America, Asia, and the Middle East, and higher in Europe, Australia, and USA. Education is associated with a later age of natural menopause, while smoking associated with earlier menopause by about 1 year. The relation between weight, exercise, and menopause, its evidence is inconclusive. Stages of reproductive aging workshop known as STRO. It is a gold standard for characterizing reproductive stages and menopause. It was originally developed in 2001 and updated in 2011, known as STRO plus 10. It uses the final menstrual period at the anchor point, with 5 stages before final menstrual period and 2 stages after it. And it uses the menstrual cycle and the endocrine profile to determine each stage. Health concern associated with may be short and intermediate term. This includes menstrual disturbance, vasomotor symptoms, and the genitourinary syndrome of menopause, while long-term health consequences include bone health, cardiovascular health, and mental health. This TOG article will focus on mental health. Starting with the first problem, which is depression. Depression is a mental health disorder characterized by periods of depressed mood or diminished interest in activities, which occurs most of the day, nearly every day, for at least 2 weeks. Most of the day, nearly every day, for at least 2 weeks. The lifetime prevalence of major depressive disorders range from 2% to 21%. A point prevalence of depression was recorded as 7.7 in women. And the highest rates are recorded in European countries, while the lowest rates are found in Asian countries. The age prevalence of depression is highest in 45 to 59 age group. Risk factors associated with depression include prior history of depression. Negative attitudes about menopause prior to menopause are associated with more problems during menopause. Age of menopause is another risk factor, and the younger age of menopause is associated with a higher risk of depression. And there is bidirectional relationship between vasomotor symptoms and depression. The next problem is anxiety. The relationship between anxiety and the menopause is not well understood. And the hypothesis that anxiety level increase during menopausal transition and decrease after menopause is not supported in published articles. Risk factors for anxiety include history of depression and lifestyle factors such as obesity, sedentary life, and alcohol intake. Regarding sleep disturbance, it is common during menopause. And the reasons may be related to vasomotor symptoms, such as hot flashes, which can disrupt sleep. In addition, insomnia may be due to a primary sleep disorder, such as sleep disordered breathing, restless leg syndrome, and periodic limb movement disorders. Note that the prevalence of sleep disordered breathing increase in women after menopause. And this sleep disorder affects mood. In addition, it is associated with cardiovascular disease. Regarding Alzheimer disease, there is no evidence of a direct link between Alzheimer disease and menopause. However, women are more likely to develop late onset Alzheimer disease than men. And now, what is the management of mental health problems during menopause? Firstly, start with assessment. Obtain detailed history, including any previous symptoms of depression and insomnia. Use a validated depression questionnaire, such as CASD, Hamilton Rating Scale for Depression, and also Mino-D questionnaire is a validated one. Regarding treatment option, this table from TOG article states that for major depression, the first line is antidepressants, while for minor depression, the first line is HRT with or without antidepressants. Regarding antidepressants, the first choice is SSRI. If not effective, use SNRI. However, side effects are more common with SNRI than SSRI. Take care, prolonged use of SSRI is associated with increased risk of osteoporotic fractures. The use of antidepressant and psychotherapy in combination is better than antidepressants alone. Withdrawal of antidepressant is usually performed gradually and 12 months after successful remission. HRT is not licensed for treatment of menopausal depression in USA and Europe. However, NICE guidelines recommend considering menopausal HRT to alleviate low mood associated with menopause. Another treatment option is psychotherapy. It includes cognitive behavioral therapy, problem-solving therapy, and interpersonal therapy. Cognitive behavioral therapy, CBT. CBT help a patient to replace negative thoughts with positive ones. It also beneficial in management of insomnia. Lifestyle changes are important. Healthy lifestyle changes are recommended as part of treatment. These include reducing alcohol intake, stopping smoking, regular exercise, good sleep, and healthy diet. Healthy diet include avoidance of sweetened and refined sugars, and intake of lactose, fruits, vegetables, and fibers. Complementary therapy such as therapeutic craniofacial massage and foot reflexology have a positive effect on women's mental health during menopause. St. John's wort is also effective. However, it may be associated with a risk of liver toxicity and drug interactions. The effect of phytoestrogen on depression, anxiety, and mood disorders remain unproven. And finally, melatonin. Melatonin is approved for treating insomnia in individuals over 55 years old. It is available as a prolonged release melatonin tablet, licensed for short term use in adults over 55 years. However, it has drug interactions. Firstly, it augments the effect of some antidepressants like dispyramine and fluoxetine. It also increases the risk of bleeding when used with warfarin. The use of melatonin requires more extensive research to establish its potential benefit.